So, good afternoon, dear gentlemen and ladies. First of all, if you may allow me, I would like to welcome our dearest professor and friend, Mr. David Ralph. It's always a pleasure to see you, and as we just discussed, it's a record for me to see you 3 times in a row in less than 1 month. I'm blessed. And welcome in Cairo, in Egypt. It's always great to see you. And second, I'd like to welcome Professor Farhat, well-renowned urologist, known for his passion for science, for surgery. And thank you so much for your distinguished and the greatest meetings that we attend. And third, I'd like to thank my dear brother and friend and colleague, Professor Ghattas. Thank you so much for inviting me to attend such an elegant and well-organized meeting. Which doesn't come as a surprise to me from a person and a team that always strive to provide the best when it comes to men's health care. So without further ado, I'd like to present to you my talk, which is on the management of long-term complications of penile implant surgery. And by long-term, I mean delayed complications, those dreadful complications that happen after a healthy and unremarkable early post-operative period. So as we already know that inflatable penile prostheses or even malleable are the gold standard treatment for refractory ED since the early 70s. And ever since, there has been improvements in techniques, instruments, and antibiotics, as we just listened to from Professor Ralph, and designs of the implants by manufacturers. Nevertheless, we still have complications, and these efforts are all for, or with one aim, is to reduce these complications. And the most common complications that come to our minds are infection, bleeding, and device malfunction. However, there are other less common complications, but still troublesome or cumbersome, especially for the non-high volume implanter. When we speak about complications, our focus today will be late post-operative complications, as we just heard a very elaborate talk by Mr. Ralph. Today, or now, we will be focusing on the late post-operative or long-term or delayed complications. We have a long list that will try to introduce to you in a time-efficient way of long-term complications, the sticky pump complication, SSD deformity, which you just listened to, delayed urethral injury or erosion, glands denervation or devascularization, penile shortening, which is a very disturbing complication for both the patient and the surgeon, and chronic pain syndrome and IPP reservoir-related complications. For each complication, I'll try to touch on a brief background of this complication, moving on to the differential diagnosis according to the clinical picture, and finally, advice and instructions for how to prevent or manage this complication. Let's start by the sticky pump complication. IPP versatility and reliability has increased with the advancements in the techniques and the devices by manufacturers, as we just mentioned, with one aim, and that is to make inflation easy and deflation easy while preventing auto-inflation. Examples of these pumps, most common or the most famous, are the momentary squeeze pump by AMS, or in our case, the Coloplast, the one-touch release pump by Coloplast. Reviewing the literature, the most common complications or the most common causes of revision surgeries are due to mechanical failure. And interestingly, 50%, almost 50% of these revision surgeries or mechanical failures were due to pump malfunction, with a common phenomenon called stiction, which means pump failure in the absence of system fluid loss. In this diagram, you could appreciate how sophisticated a pump is on the inside. And by the way, this is the one-touch release pump by Coloplast. So, elaborating on the problem itself, when we say sticky pump or stiction, or sticky pump or pump stickness or pseudo malfunction, they're all synonyms to the same problem, where you have a fixed deflated pump in the deflated position, which is incompressible or hard to decompress. And that, of course, in turn leads to increase in the number of postoperative sessions for treating and practicing and postoperative follow-up. It could happen anytime, could be early, could be late, and could be recurrent. But the most, or the common factor in all the cases is an idle pump not used, not cycled for at least 6 months, 6 weeks. Prolonged inactivity leads to component static friction, and that is by the laws of mechanical engineering. The more static, the more friction you have to overcome when you come to use the pump afterwards. In other words, resistance. So when we come to differentially diagnose, when you have a case or a case of persistent pump malfunction, it could be due to disruption in the hydraulic loop, which is true malfunction, opposed to sticky pump or pseudo malfunction. Presentations will differ according to the nature of the defect, where the defect lies. Failure to inflate despite repeated compressions, and you may recall that characteristic whistle or hissing sound of leakage, and that equals leakage. It could be also due to minute tears over the time, which leads to decompression failure and slow erection performance or erection quality over time. Or sometimes a sticky pump may be true sticky pump due to hindering tissues or hindering capsule around the pump, as Professor Ralph just stated, when you, for example, as in a case of postoperative hematoma. So the key to management is prevention. And I think all of you, if you assemble the device yourself, or like in our case, we're kind of spoiled here in the Middle East, we have the representative that assembles the device for us, you could watch him while he does the characteristic of lubricates the pump. So the key is lubrication, proper lubrication at the beginning of the procedure, by injecting under pressure saline into the pump and cycling several times. Then afterwards, post-operative, you must maintain regular cycling, but sometimes you have to defer in cases of pain, but try not to exceed the period of 6 weeks, as we mentioned. And I use a piece of advice that I give to my patients. I call it cock your gun, as if you're getting ready for the next time. When you do complete deflation of the device, it's always good to advise your patient to just give one press on the pump afterwards. That lodges the valve back in place, making it easier on your following utilization of the device. So as I mentioned, treatment could be conservative, could be active. In case of conservative, there are examples for the momentary squeeze, forcible deflation, and I'll show in a picture afterwards, or forcible inflation in case of the one-touch release pump. Pump release can also be done under anesthesia if you fail all the previous measures. Here's an example of the forcible deflation, where you squeeze the shaft of the penis while pressing on the deflation button. In the case of a one-touch release, you try to maintain a good angle or straighten the exit tubing from the cylinders while forcibly pressing on the pump instead of deflation in this case. Here's another picture of active treatment where you have to actually intervene, go to surgery, and release the tissues surrounding the pump and put it in a dependent position. Moving on to our second complication, SST deformity or supersonic transporter deformity. Is this really a complication? Is it true or is it false? SST, as you can see from the picture, this resembles the drooping glands, which is another name for the drooping glands deformity or complication. As I said, is it false? Is it true? False in cases, as we just learned from Professor Ralph, is improper cylinder length or positioning, undersizing. True, that's actually rare to happen, but that is due to the deficiency of the natural intrinsic support under the glands, which most probably is due to ischemia over time. It causes problems for the patient, who's both cosmetic and functional, and the best test to differentiate between true versus false is the pull-down test, a very simple test where you just pull down on the skin of the shaft. If it resides properly, then most probably it's an undersized cylinder. If it still remains deformity, then you have a true drooping glands due to decreased support. Here are the two examples in pictures. On the left side, this is a picture of undersized implants. And on the right side, this is a true SSD or a true drooping gland due to decreased support. Number one in management is to properly delineate which type of SST type you have. And like I said, simply by the pull test. Treatment can vary from mere observation to medications to surgery. You can wait and see for at least 3 months for the capsule to form. Sometimes it could provide support, and there you go, then you will be good to go. There are medications that have been proposed as using PDE5 inhibitors, intraurethral prostaglandin injections, maybe glands bulking with bulking agents, or finally surgery. And surgery differs if you have a false versus a true. Here's a nice algorithm that shows you how to manage such a complication. And it starts by the pull test, and accordingly you manage your case. Example of an undersized drooping glands or undersized cylinder, undersized device that led to drooping glands, fixed by simply upsizing or exchanging your device. And here are examples of surgical management of the true drooping glands that have been evolving along years. The ball technique by single suture through the depth or the base of the glands. Then the mohawk technique using smaller incision and multiple sutures. Even smaller incisions have been introduced. And this is a technique that has been introduced by just simply plicating dartos and skin to correct your complication. But my personal experience is that I don't advise this technique because I tried it once, and over time the skin tends to stretch again, and recurs again the complication. So I would advise going with the definitive glanduloplaxy as Professor Ralph just showed us. Our third complication on our list today is delayed injury or erosion of the urethra. The problem with this complication is that it's unpredictable. It could happen weeks, maybe years post-operative. The reason behind it could be iatrogenic because of aggressive dilation, faulty cylinder positioning or sizing, or maybe during modeling technique for correction of curvature. It could be subtle, it could be missed intraoperatively, and in turn you end up with a fistulous tract. Other causes may be catheterization or cystoscopy due to friction with the implant, and that happens in certain populations as diabetics, paraplegics, maybe post-irradiation that have poor quality of tissues. And the number one risk factor is urethral anatomy, especially distally where you have the weakest part of the urethra, as you all know, the fossa navicularis. The clinical picture ranges from hematuria to glands hyperemia, burning micturition, maybe infection, or penile implant erosion through the urethra. Here's an example of urethral perforation, and which was evident by doing one of the important safety checks, as we just learned again from Professor Ralph today, the water check test. You have a distal perforation, and this occurred during dilatation, and it's more common to happen in revision cases. Here's another example of perforation. On the left side, this occurred weeks after surgery, induced by infection. On the right side, this happened years after surgery with an inflatable implant. Number one in treatment is prevention, and the key again is anticipation. You must anticipate the problem before it's too late. And it starts by planning, proper planning, and you have to have the adequate experience and instruments, especially in those challenging cases we just mentioned. Always protect your urethra. Always secure your urethra by your non-dominant hand. During dilation, always keep the urethra away. Keep your dilation lateral and dorsal as much as possible, away from the thinnest and weakest part of the urethra. One of the techniques to avoid distal perforation is to squeeze or pinch the glands during dilation. So you have a safety stop during dilation. If you plan on doing modeling for a case of penile curvature, try to apply the pressure on the shaft opposed to on the glands. And in some cases, rare cases, you may opt for a perineal uretherostomy or a suprapubic tube instead of clean intermittent catheterization in those special cases or certain population we just mentioned. Here's an illustration of the modeling technique. As you can see on the right side, always apply pressure on the shaft, not on the glands. When it comes to treatment, it's according to the presence or absence of signs of infection in cases of urethral injury or erosion. If you have erythema, pain, or discharge, I would advise total explantation with delayed revision. If the cylinder has already eroded, then that is a potential, or we consider it contaminated already. Then again, you have to treat it as a potential infection and exchange the device. In absence of infection, you're allowed to remove the offending cylinder and leave a urethral for 3 days. That'll be sufficient. And you may also implant a single rod in the intact corpora or bilaterally if the repair was, or if the defect was repairable from the beginning. Here are examples. On the left side, you have a case of impending erosion through the urethra, which was corrected, as you can see on the right-hand side, by simply revision and undersizing of the implant. And actually, in this case, I took like a couple of fixating sutures on the distal tips of the corpora on both sides for extra support. Our next complication on the list is glands devascularization or denervation. It's a really dreadful yet rare and underreported. That's why it could be challenging sometimes. The typical presentation is the change of the color of the glands. Most commonly, it would be dusky. Sometimes you could have blisters on the glands as well. Although the rich anastomosis of the dorsal, glands sourced from the dorsal penile artery plus the bulbourethral artery, there still are predisposing factors to this kind of complication, especially in when you have the risk factors, the same risk factors for peripheral vascular disease. For more than 90% are due to novel surgical approaches, ancillary procedures that we do during surgery, like, for example, the approach of the degloving approach, especially in certain cases that are predisposed to such a complication, excessive mobilization of the maybe neurovascular bundle or the urethra, and in some of the lengthening procedures, some of which have been discontinued due to this complication. And 70% were found in the literature due to pressure bandages, the mummy wrap, when it's over tight, with pressure is over overpressured. I mean the glands, the shaft. And the problem is it cannot be predicted by imaging. Here's are pictures for variants of devascularization, where you have the famous dusky glands with the blisters, more darker glands, and a full picture of gangrene on the right-hand side. Here you can appreciate the rich anastomosis supplying the glands. Nevertheless, with excessive mobilization of the neurovascular bundle or the urethra, that could predispose you to such a complication. So to prevent is to try to avoid extensive adjunctive surgical approaches, especially in the risky patients that have risk factors for peripheral vascular disease. The dilemma is always how to manage, because there isn't a certain or a definitive protocol established to date. To conserve or to intervene still depends on the clinical picture and the surgeon's opinion. But the number one important factor is to differentiate between cases of dry gangrene versus wet gangrene. In case of dry gangrene, you may observe and debride according or on demand, But again, you have to weigh the risk versus the benefit of doing applying such an approach. But if it's a wet gangrene, then that means infection. Then the only choice is immediate explantation, debriding, and even partial amputation. The bottom line is that you must be assertive to avoid inevitable glands tissue loss. And as we just heard from Professor Ralph, once in doubt, you should take it out. Here's an example of a case of glands gangrene. Actually, it was dry, but like I said, you have to weigh the risk versus the benefit. Maybe the surgeon waited too long, which led to the loss of the glands total. Moving on to denervation, the penile dorsal nerve injury or its branches is very rare, yet again, dreadful. It could lead to irreversible sensory loss of the glands, and you can imagine what that could cause to the sexual performance and function of the patient. You must be aware and be careful, especially in high-risk patients with distorted anatomy, extensive fibrosis, previous surgeries in that area. And always be careful when you come to dissect the neurovascular bundle to ensure the integrity of the neurovascular bundle. Moving on to our other complication, which is penile shortening. Like I said, it's a pain to both the surgeon and the patient. But the number one cause is unrealistic post-PPI expectations in comparison to the pre-dysfunctional sizes. So sometimes we are the ones to blame for this kind of complication. That means that you didn't invest enough time in preoperative counseling with your patient. And you have to have a good eye for those special patients that need maybe extra counseling, like the ones that are called the cursed patients. And that, of course, leads to decrease in postoperative satisfaction rates despite a successful surgery. And you find this complaint more with malleable compared to inflatable devices, and that again shows the advantage of inflatable devices above malleable. And that is due to the uniform and solid nature of the malleable compared to the pliable nature of the inflatable, and it allows you to maybe oversize or let's say maximize the size. Yet it's still a complaint even when you use an inflatable device. The causes of penile shortening, as I mentioned, could be false, could be subjective, just related to the patient's perspective, or maybe true, objective. And the reason behind subjective feeling or sense or complaint is the long history of ED. So the patient actually forgets, doesn't have a correct recollection of his original size, before he had his problem. And it could be objective, true, and that's in cases where fibrosis leads to shrinkage of the patient, like shrinking of the size of the penis. In cases of Peyronie's disease, decreased glands engorgement due to deficient arterialization of the shaft or the penis, corporal fibrosis, or ischemia. Reviewing the literature, you find studies controversial. Some studies find no difference in objective length. Some studies even find an increase in length using an implant, or especially an IPP, yet it still remains a complaint. This is a nice table that shows the different approaches or measures that you could apply or opt to maximize or enhance the size. It starts early on before surgery by penile stretching, maybe using a vacuum device. Early intervention when a patient is indicated for an implant, go ahead with it quickly, don't wait, because the longer you wait, the years go by, the smaller or the shorter the penis. During surgery, there are different approaches that have been proposed as well. Like we saw today, ventral phalloplasty or scrotoplasty. And after surgery, surgeons have proposed using augmentation, using fillers, glans augmentation, or maybe if you have a true undersized implant, you should revise it and correctly size your implant. This picture shows you this was from a nice paper that showed the increase in size over time by using a vacuum device, daily usage of a vacuum device for 8 weeks before surgery. Here you can appreciate the difference in size before they started and at the end, right before surgery. Here are other pictures of examples of lengthening techniques, surgical techniques. Like I said, some that have been now discontinued, discouraged due to the complications. Sclerotoplasty or ventral phalloplasty, as we just saw in the previous talk. And I think this is our, not the last, this is right before the last. I thank you for bearing with me. The chronic pain syndrome. It's not uncommon. Rarely does it lead to device removal. It could be around any part of the device, cylinders, rods, reservoir, or pump. Pain is considered chronic if it persists beyond 6 to 8 weeks, and it could remain for years. The problem is the cause or the physiology behind it is poorly understood, but what we understand is that the genital area is very sensitive due to its high nerve supply, cutaneous nerve supply, thus, hence the lower pain threshold. More common in diabetics due to the associated neuropathy, which complain of more severe pain versus non-diabetic patients. And sometimes chronic pelvic pain itself could be another form of pain following penile implant surgery. You must differentially diagnose it from subclinical infection, could give the same clinical picture, maybe faulty sizing, oversizing, or positioning of the prosthesis. For example, crossover, as we just saw, and diabetic neuropathy associated. I think that the best measure for this, or the best approach for this kind of complication, is to try to be wise as much as possible. Start by reassurance and watchful waiting, allowing tincture of time. I mean, time does magic in these cases. Always reassure your patient. But sometimes medical surgical intervention may be mandatory, so you have to be wise when to choose when to intervene. When pain persists beyond 6 weeks in a properly sized implant, you must be suspicious of preclinical infection. And there's a nice test you could use, which is the antimicrobial test. If pain subsides, then that most probably means it's an infection. And it's confirmed once you stop the treatment, the symptoms recur. In that case, you should urgently or immediately implant, go to salvage revision, or explant at least. An MRI is an important and very useful tool to diagnose chronic penile pain, suspected if you have a wrongly sized or positioned implant. Like I said, try to be wise as much as possible, conservative as much as possible, provided it's not an infection, of course, because surgical intervention by itself could lead to further complications, as shown by literature that in 68% of the cases it was of no use or futile, but it remains that absolute indications are infection or oversizing. You must intervene to prevent further complications. This is a nice and easy cause of chronic pelvic pain, which are the common dog ears which we see after inflatable implants. All you do is just reassure the patient that it goes away by time, especially after 3 months when you have an extra layer of capsule that forms around the implant. Another piece of advice is to maybe keep the implant semi or maybe under semi-inflated to avoid this acute angle in the device. This was a cause of chronic pain at the tip of the glands due to oversized oversized malleable implant that was cured just by resizing, undersizing the implant, revision and undersizing the implant. And our final complication today, which is the reservoir-related complications. As we all heard today, that traditionally the place for the reservoir was the space of retius. I know it's rare, but it may cause life-threatening complications due to the blind nature, and like we saw, if you forget to empty or evacuate the bladder, you could end up with a fistula or maybe a migration of the reservoir within the urinary bladder. And this led many of the surgeons nowadays to adopt the ectopic or the high submuscular ectopic placement of the reservoir just to avoid these kinds of complications. And the key is when you come to implant it ectopically or high submuscular is to stay medial and high as possible. These pictures show you two examples of these kinds of complications. On the left side, you can see a palpable and visible reservoir in the high or in the ectopic placement. On the right side, this is not visible, yet it is palpable. So how do you deal with these kinds of cases? I would wait for 3 months for a capsule again to form around it. The other thing is that, with the patient's activity, especially if he has a good muscular support of his abdomen, that would tend to compress or press the reservoir backwards towards the least resistance of the peritoneum or the transversalis fascia. According to the proper study, pain or herniation was higher in the high submuscular group opposed to deep pelvic complications in the traditional space of retius group. Therefore, many surgeons consider the high submuscular placement of the reservoir to be safe, efficacious, with excellent satisfaction, even, as we just mentioned, even if initially palpable or visible. And as Professor Wilson always says, what worse can happen following a high submuscular placement than it just to be visible or palpable? And fortunately, most patients, if not all, will never request a revision. Thank you.